Welcome to the class, dear doctors. Pediatric cardiology class, 𝗲𝗵𝗵𝗵𝗵. I am Dr. 𝗵𝗵𝗺𝗺. I am your pediatric faculty. This is the session where we are going to discuss an extremely important purpura. Actually, these purpura are more of the concern of vasculitis. These purpuras are going to develop because of vasculitis. But since I feel that this is not directly related to your cardiology, but this is an extremely important topic, so I just have combined this Henoch-Schönlein Purpura with the cardiology. Okay. So without further ado, let's understand what this purpura is. Henoch-Schönlein Purpura, what does it mean? So Henoch-Schönlein Purpura is the most common vasculitis in the children. So this is your vessel, and the vessel is going to show you vasculitis. That means it is going to show you inflammation. So there is inflammation that is going to occur in the vessel. Okay. And why this inflammation is going to occur? Because of the antibodies produced against this vessel. Okay, antibodies are going to get produced against these vessels. And which type of antibodies? Immunoglobulin A. So immunoglobulin A is the antibody which is produced. So Henoch-Schönlein Purpura, first point to remember that it is a IgA mediated small vessel vasculitis. Okay. Small vessel vasculitis. Now it is, first thing, it is IgA mediated. Second thing, it is a small vessel vasculitis. That means which vessels are going to get inflamed? Arterioles, capillaries, venules. Not the arteries, not the veins. Arterioles, venules and capillaries are going to get inflamed. Okay, so this is IgA mediated vasculitis. Now what happens is, why does it happen? It happens secondary to a upper respiratory tract infection. Okay, so it is often preceded by an upper respiratory infection, like viral infections or Group A Streptococcus. Group A Streptococcus is actually an important risk factor. So this is the third thing you have to remember. First, IgA mediated. Second, it is going to be small cell vasculitis. Okay, S for small cell vasculitis. Then S for Streptococcus. So S for what? S for Streptococcus is going to be involved. It's a risk factor. So what does it lead to? Of course, it leads to deposition of IgA and deposition of C3 and fibrin in the vessels. The fibrin is going to get deposited, the C3 complement is going to get deposited, and IgA is going to get deposited. Now this IgA is actually responsible for damaging the kidney also. So IgA is responsible for causing the vasculitis also, as well as damage the kidney also. So generally, whenever the IgA vasculitis is happening, it is associated with IgA nephropathy as well. Okay, so it is associated with IgA nephropathy also. Coming on to the next part, what is the feature which will be there? There will be purpura that will be palpable purpura. There will be what purpura? There will be palpable purpura, because this purpura is going to happen because of vasculitis. So it's a palpable, just as you can palpate your pulse, the purpura can also be palpable. So it's a palpable purpura. You have to remember this is a palpable purpura. Okay, palpable purpura. So P for what? P for palpable purpura. Palpable purpura. Yes, next, it is also associated with polyarticular arthritis. There is a polyarticular arthritis which is going to be there. Polyarticular, that means different joints are going to get involved. Polyarticular arthritis. Okay, so this is a polyarticular arthritis which is going to be there. Then what is coming from this A? This A is responsible. Okay, one A is IgA. Next A is abdominal pain. It's going to be what? Abdominal pain. This is going to be a colicky pain. And one is going to be the renal involvement. Okay, renal involvement. So what is important from R is the renal involvement. I have told you renal involvement already. Yes, I have told you renal involvement already, that IgA is going to affect two things. One is going to be the renal involvement. And what is where will you see the purpura? That will be seen on the extensor surfaces. That will be seen on where? That will be seen on extensor surface, like the arms, like the buttocks, like the legs. Extensor surfaces is going to be there. Now, important point you have to understand that this is a non-migratory arthralgia. There is non-migratory. It doesn't mean that it will start from the knee, then will come to hip, then will come. It's not going to migrate. It's not going to migrate. These are going to be simultaneously produced. Okay, occurring in the shoulder simultaneously. It's not migratory. Okay, so it is a non-migratory type of arthritis or arthralgia which is going to get occur. Now one important thing is that, you know, there is a huge risk of intussusception which can occur. Now, what is intussusception? For example, this is the bowel valve, and what happens, this bowel valve is going to get folded down, and after folding down it is going to get folded on itself. This is called as intussusception. That means one part is inserting into the other part. Okay, this is called as intussusception. So intussusception risk is very high. Alright, so R was important for the renal involvement. I have told you. What is the R? R is actually renal involvement. So there will be hematuria and proteinuria which is going to be there. Hematuria and proteinuria which is going to be there. And I think I have discussed already, there will be D for deposition. Deposition of what? Deposition of IgA, deposition of complements that is going to happen. What was from N? There is a non-migratory arthralgia. What is R? Renal features. And what is I? I is actually the yes, intussusception risk. Okay, the risk of intussusception is also high. Okay, so the mnemonic as far as of now is passed NRIs. So all the NRIs are passed. You will also be passed. Okay, now coming on to the clinical triad. Okay, so the clinical triad is going to be what? One is going to be the palpable purpura. Next is going to be what? Palpable purpura is there. Next is going to be what? Abdominal pain is going to be there. And of course the kidney feature, the renal features are also going to be there. Now please, one important thing is there is no thrombocytopenia, there is no coagulopathy, there is no thrombocytopenia which occurs in Henoch-Schönlein Purpura. There is no thrombocytopenia. Okay, in Henoch-Schönlein Purpura there is no thrombocytopenia. Please remember it always. Okay, it actually tells you Schönlein. Okay, SCHONLEIN. So NO means no. H for hematological disturbance. No hematological issue means there is no coagulation which is going to occur. I told you, yeah, there is no thrombocytopenia which is going to occur. Okay, so this is important. Please don't forget it ever. Henoch-Schönlein Purpura, so I have discussed, I think most of the things we have discussed. Yeah, so the classical triad or tetrad, you can say, one is going to be non-thrombocytopenic palpable purpura. The picture is evident, the purpuras. There is abdominal pain, I have told you, there is a colicky pain, and there is hematuria, okay, microscopic hematuria, and of course the arthritis can be there. Yeah, so the triad also, if you see, you have got palpable purpura, the abdominal pain, and the joint involvement is going to be there. Okay, joint involvement, this is a more commonly used triad rather than involving the renal involvement. Okay, so how will you diagnose this? So in the skin biopsy there will be IgA deposition which is going to be there. The antibodies are going to get deposit here, and of course there will be leukocytoclastic vasculitis is going to be there. You know, the WBCs are going to come, and WBCs are going to destroy the vessels. Okay, and the WBCs are going to come and going to destroy the vessels. In urine, of course, you will be having the RBC cast, the proteins, the blood, the kidney's mesengium is also going to have the IgA deposition. The treatment, usually the vasculitis is actually self-limiting. You just give proper hydration and NSAIDs, and prednisone is given. Okay, prednisone is something which is given in these cases. What does prednisone do? Prednisone is actually what? Prednisolone is actually a corticosteroid. So corticosteroid is given to do what? To decrease the inflammation. So it is going to decrease the inflammation, it is going to decrease the vasculitis, and because the vasculitis is decreased, there will be decreased risk of renal damage, decreased risk of recurrence and everything. Also, because of this vasculitis, you know, the very first thing in inflammation, if you remember, the very first thing in inflammation, what happens is from your pathology is the vasoconstriction, and this vasoconstriction is responsible for doing the hypertension. So we have to give some antihypertensives also in this case. And what are these antihypertensives which are given? This is the ACE inhibitors, angiotensin convertase enzyme inhibitors. And if in any case, because of the damage of the vessel, there is a blood leak, there is a fluid leak that leads to edema, so we have to give diuretics for the treatment of the same. Let's quickly discuss about these important images. This is a kidney biopsy. Okay, this is a kidney biopsy, and can you see that there are IgA depositions? So these are actually the depositions, okay, in the mesengium. In the mesengium there are depositions which are there in IgA nephropathy. This is also IgA depositions actually, but you know, not important for the UG level. I was supposed to show, so I've shown you. Yeah, these are the purpura. Okay, these are the important purpuras, Henoch-Schönlein purpura and everything. Palpable purpuras, again palpable purpura on the foot, okay, on the dorsum of the hand. Okay, see more pronounced in the extensor surface. Extensor surface, it's more pronounced. Okay, these are the purpuras on the butt cheeks and everything. You can see very well here. So this is about the Henoch-Schönlein purpura, and this marks the end of pediatric cardiology. The heart-to-heart connection with the cute little children in the subject of pediatrics now comes to an end. We'll see you in the next chapter. Thank you.